Hello and welcome to the 2015 CROI here in Seattle, Washington. My name is Christopher Brennan, representing IFARA TV. I have with me today Janet Lowe from Massachusetts General Hospital. Hello, Janet.
Hi, Chris.
You're also affiliated with Harvard Medical School.
Yes, I am.
And I know that today we're going to talk about the statin study that you were working on and presented at CROI, and the impact and effect that it showed on coronary plaque buildup. And maybe before you get right into that, you could tell us a little bit about yourself and a little bit about your research interests in general, and then move into the study.
Okay, sure. Well, thanks for inviting me to be here today. So my name is Janet Lowe. I am a clinical investigator at Mass General Hospital and also an endocrinologist. My research focuses on metabolic and cardiovascular issues in HIV patients.
Mm-hmm. And so how about we talk a little bit about the statin study that you presented. What was the lead up to the study? What was your study question?
Mm-hmm.
How did you pick it? And how did you go about executing it?
Sure. So before we started this study, we were learning, and other groups were learning too, that HIV patients have an increased risk of heart attacks. And we had previously done another study, which was published in 2010 in AIDS, where we use CT angiography to look at the coronary arteries of HIV patients. And these are patients who did not have any symptoms. What we found was that many of them actually had plaque present that they didn't know about, and it was about a 59% prevalence. So 59% of the patients who we enrolled in the study who did not have clinical cardiovascular disease, it turned out that they had some plaque present. Some of them had severe plaque that were quite surprising and needed treatment for, and some were mild. But it was a high prevalence of coronary atherosclerosis, and so we were concerned about that. And around that same time, other groups also found very similar findings. So we think it's a real problem that coronary artery disease in HIV patients may be very prevalent, and and one worry was that it might progress quite rapidly too, and what can we do about it? And so we wanted to study a medication which has known beneficial effects on preventing heart attacks. Mm-hmm. And also, there's been prior studies in the general population that have shown that a statin at high doses can reduce plaque. And this was done using intravascular ultrasound, a very different method, which is a bit more invasive. And so we wanted to visualize the plaque in a non-invasive way. So we use CT angiography. So patients would undergo a CT scan that's enhanced with contrast, and that would allow us to visualize the plaque. Mm-hmm. And so basically, we wanted to use a statin for its anti-inflammatory properties, as well as its effects on cholesterol, the bad cholesterol specifically. So we hypothesized that a statin can reduce plaque through many different mechanisms, but we thought that it would make sense that a medication that can reduce plaque burden in the general population, and also reduce bad cholesterol and reduce inflammation, would probably be quite beneficial in the HIV population.
Mm-hmm. Yeah, and the visualization that you get mm-hmm. from the CT scans is mm-hmm. how good is that?
So it's actually quite good. There's been many studies now from cardiac imaging specialists around the world that have looked at CT angiography, and it's also used clinically to look at cardiovascular disease, specifically to look at plaque and other parameters too. And so it's a clinically useful test, not recommended necessarily necessarily for screening purposes, but you know, the pictures you get are really nice. You could see the coronary arteries and the plaque within it. You could see different characteristics, you know, of the plaque, whether it's non-calcified, calcified, if it has features that may suggest it may be vulnerable to rupture. So I think it's a powerful, you know, imaging tool that we have to look at coronary atherosclerosis.
Right. And can you talk a little bit about the population that you chose for the study? One reason that I bring that up is because some of the discussions that we had earlier in our interview sessions were around late onset cancers that affect disproportionately are affecting individuals who are living and are later in their life now, having lived on different antiretrovirals for a number of years, maybe some that had more toxicities or more, you know, there's a different pharmacokinetic spectrum around various combinations that you can have. And as the drugs have improved, the outcomes of long-term outcomes of what might happen for currently young, you know, newly positive patients might be different. So in that way, can you speak a little bit about how you chose your populations to look at their you know, plaque, and if certain combinations of drugs end up increasing the atherosclerosis more?
So Chris, it's a, you know, good point you bring up. HIV patients are now fortunately living longer, healthier lives thanks to antiretroviral therapy, and you know, but you know, with this population now, you know, growing older and also experiencing, you know, long-term effects of antiretroviral therapy, as well as just having a chronic infection, you know, even though the virus can be suppressed, you know, by the drugs, there's still low levels of virus around, and that, you know, what are the long-term effects of having this HIV viral infection, as well as being on medications, you know, what can that have on different organ systems? And one worry is that cardiovascular disease is, you know, one emerging problem, you know, in the HIV population as they grow older. And we think that the chronic inflammation that HIV patients can experience through chronic infection, even, you know, at low levels of virus, probably plays an important role. That, you know, that chronic inflammation, you know, from activation of the innate immune system probably can lead to more heart disease, as well as other problems too. And so we want to study this population, and for inclusion in our study, we specifically chose patients who were on stable antiretroviral therapy. You know, as I mentioned earlier in my presentation, these are patients who do not have cardiovascular disease that they know about, and they do not have any symptoms. But we wanted to see if they had plaque in their coronary arteries, and so we did a CT angiography first to screen and see if they had plaque. And if they did have plaque present, we asked them to be in our randomized trial. And if they had too much plaque, we actually, you know, told them about, you know, all their results, and you know, would exclude them because it wouldn't be ethical to randomize them to placebo.
You might link them to some kind of other therapy.
Right, because if they had, you know, critical stenosis, they needed to be treated right away, and so we would recommend for them to see a cardiologist and get it evaluated and get treatment. So the patients in our study were patients who had plaque present, but not, you know, to a severe degree that they needed, you know, treatment for it. And we recruited patients who had LDL levels less than 130, so that if they were too high, they probably would need to be on a statin medication anyway. So we wanted to take patients who would not necessarily meet criteria to be on a statin, and then, you know, this way it would be ethical to randomize them to either a statin or placebo, because you don't want someone who needs a statin on a placebo.
Right.
So that was the patient population that we recruited.
Okay, interesting. Can you tell us a little bit for background for our audience, what the mechanism of action is of a statin? How does it end up reducing plaque buildup and cholesterol?
Yeah, so statins, they're HMG CoA reductase inhibitors, and basically they can lower your bad cholesterol, LDL cholesterol. And so that is one mechanism that people think it can help to prevent plaque buildup. But statins also have other effects. For instance, it has good anti-inflammatory properties too, so it can act on the immune system, and hopefully it can decrease some of the detrimental immune activation that HIV patients may experience. And so by decreasing pro-inflammatory monocytes and pro-inflammatory T cells, it might help to reduce inflammation, and by reducing inflammation and reducing those cells that might be contributing to plaque buildup, statins may help in that way as well.
Okay, so you got your patient population in, we randomized them, we selected our statin to use, you gave it to them and monitored them. What was the outcome?
So the outcome that we found out that was most interesting was that it reduced the plaque volume in the coronary arteries. So we looked at total overall plaque volume, so any plaque, measured the volume, and after 1 year measured it again. So statins did reduce that, and whereas in the placebo group, the plaque volume actually increased, which was worrisome. And we also looked at non-calcified plaque volume. That's the type of plaque that has been associated possibly with future events, and so it also significantly reduced non-calcified plaque volume.
And was the reduction in volume so impressive in a way to suggest that you would start to think about linking patients to statin use on a regular basis?
So the reduction was impressive. However, our study was small. And so I don't think it provides definitive data in order to recommend statins for all HIV patients. I think future larger randomized trials will be needed in order to really prove that, and I think a future trial that can assess event outcomes in HIV patients would then be able to better address whether or not we should recommend statins for all HIV patients. I think an HIV patient who would meet current guidelines for an statin therapy should be on a statin, but whether all HIV patients need to be on a statin, that remains to be answered by a more definitive trial.
Right, and it probably will be individually based eventually when it really does come out. Do you know
Absolutely.
if any of those trials, larger next step trials, are being talked about or in the works yet?
They are, yeah. In fact, in Dr. Stephen Grinspoon's plenary talk today, he talked about a trial that's starting. It's called Reprieve. It's funded by the NHLBI with also support from the NIAID, where they are going to assess event outcomes in HIV patients, and they are going to be treating them with pitavastatin, which is a newer generation statin that may have less side effects and less drug-drug interactions with protease inhibitors. And so that trial will be starting very soon, and it's a large study with 6,500 patients.
Oh, great.
Planned.
And that reminds me, I wanted to ask you, what is the life of a person who's on statins regularly like? Is it one pill once a day, or are there
It's usually one pill once a day.
And the drug-drug interactions and side effects that you might expect?
So it depends on the statin, which one it is. So for the study that we did, we chose atorvastatin. This study was started back in 2009, so some of the newer generation statins weren't available yet. Atorvastatin was thought to be safe and well tolerated in HIV patients, but there still may be drug-drug interactions with protease inhibitors, especially boosted PI regimens. So that is still something that a clinician would need to be cautious of. So atorvastatin can be given once a day. It's we found that it was well tolerated and fairly safe.
Yeah, great. And what about lifestyle changes that are recommended also at that time? What could our patient population be considering doing to boost the power of the statin, or maybe try and avoid it altogether if possible?
I think lifestyle, modifications to decrease cardiovascular risk is first and foremost. It's the most important thing, and I think whether or not a patient is on a statin, they should always, make sure they do everything they can in terms of diet, exercising, smoking cessation, to do all the things they can to prevent cardiovascular disease.
But when we're talking about HIV population,
right,
you have, of course, the problem with this increased inflammation. So they could be doing all the right things and still not be getting that plaque buildup.
That's true.
To go down.
That's true.
But so frustrating.
It is frustrating, but the lifestyle changes still do help, and I think need to be very clearly emphasized for every patient.
So this is a great study that will set us on the course to the next one. And can you tell us, in general, at the conference, have you seen anything that maybe you've been excited by or intrigued by while you've been here at CROI?
Well, there's been so many great presentations and a lot of interesting data presented. It's hard to pick.
Right.
Yeah.
Maybe something that was on the same panel as you, so then it might be fresh.
Sure. If in terms of any studies that I think would be particularly interesting.
Or, yeah.
So I actually, all the studies presented during my session were very interesting and very clinically relevant. And it was a session on cardiovascular disease, bone and kidney health, so a very broad spectrum. So so it's I think it would be hard to just pick one, because they're studying different organ systems.
Right. The message
but there are a lot of great ones.
There's a lot of great ones, so we should check them all out.
That's right. Yes.
Take the time and study those papers. Well, I think that's all the time we have, and I want to thank you so much for coming out and talking to us today and sharing this with us.
Oh, thank you, Chris.
Thank you.